Hello, my name's Chris Tiplady. I'm a consultant haematologist and work in a busy district general hospital. And for the next 30 to 40 minutes, I want to talk through the subject of breaking bad news in haemato-oncology. I've left my face on the screen just so you can see me. At times I'll turn it off. It's quite strange doing a talk when you can't see your audience. And I'm trying to imagine where you all are and thinking of you in a different place. It's an extreme honor to be doing this for the Gardner College of Physicians and Surgeons. I've never spoken, I've never interacted, and I've read a lot about you since being asked to do this talk. And I'll be really, really pleased to hear from any of you on email or Twitter, whatever you want to do. But I'm going to try and engage and pretend you're all there and pretend you're all listening. Hopefully you're all awake. It's a sunny afternoon for me in the northeast of England. It's coming up to my weekend. I'm looking forward to a few days away. So hopefully the next 30 to 40 minutes will give you just some stuff to think about and start exploring what you already know and how you might develop in this particularly important area. I am a hematologist. I will try to share stories. I'll try to share some amusing things if I can in an area which maybe isn't always thought of to be amusing. You can see a beautiful neutrophil alphabet on the right there. This is illustrating the A to Z of how we might break bad news. And there's a few things I want to talk about today as we go through the topic. And I think it's really, really important to acknowledge culture and where we're working and the people that we see every day, their expectations, their knowledge, their assumptions. That's something I'm going to talk about today. I'm going to talk about how you might cope with this. We have to acknowledge that breaking bad news and giving bad news to people is quite emotionally stressful. It's quite difficult. It might prey on your mind. It might keep you awake. It might disturb your day. So I'm just going to share a few of the things that I do and that I know from some work I've done with colleagues in the psychology department that can help you in general. I'm going to focus in on one model called the spikes model, which is a model of breaking bad news. There are several models, but this one will be the one that I cover today, just to give you a little bit more understanding of a model that might be useful to you. But the first thing I want to talk about is culture, and I want to share with you where I am in the world at the moment. I love pointing at my map. That red area there is the area of the UK where I live, the northeast of England. I'm roughly under the T of East. That's where I live, work. It's where I was born. It's where I was brought up. I've done all of my childhood, all of my learning, all of my jobs within 60 miles of where I am now. And I don't know if that sounds sad. I don't know if that sounds happy. I don't know if I should be proud or ashamed, but it's where I am. It's where I'm from. And I'm very, very proud of it. And I think that's just starting to touch on how you have to think about this whole area as knowing your people. This bridge above me is the famous view in Newcastle, the town where I live, where my dad was born, where I grew up. And this area has been redeveloped since I was a child. When I was a child, this bit was a little bit sad. It was a bit tired. It was a horrible, smelly river. Things went down there to die. There was bits of old seagull floating past and horrible smells from the old works. Newcastle, when I was a child, was a huge mining town. Coal mining was the history of Newcastle. A lot of manufacturing. There's a lot of fishing, and the Tyne has always been an extraordinarily busy river. Very industrial area. Looking up and down the horizon there, you might spot a church or two. On the left there is a naval area where there's links to the Royal Navy. Across, right in front, over that bridge is the Royal Courts of Justice that we have there. And then the Tyne Bridge, famously the Blue Arch in the background, and this beautiful bridge in front of me called the Millennium Bridge, which is also known as the Blinking Eye Bridge. It swings and rocks like that to close. And this is the area I grew up. I know people from around here. I understand what drives them. I understand what makes us tick. It's a very proud area. People have particular hobbies and cultures and things that they like doing. The Tyne is often referred to as home. These bridges are really recognizable. We know that people like shopping around here. There's quite a nightlife in that town that you can see. Downstream that way, there is a beautiful coastline. There's lots of old mining works now. All that mining is closed, and they're all beautiful walks. It's beautiful countryside. There's a beach. We're not far from some very beautiful areas of the country as well, like the Lake District in the northwest of the UK. And I know people from around here. I don't know people from other areas of the country, or even other countries. I have a few, obviously, acquaintances and colleagues, but knowing that culture from another place, another site, is very, very difficult. So when I'm talking today, it's coming through the lens of somebody who's been brought up here. It's that lens of someone who understands a heritage, a past, a culture, an upbringing, ambition, expectation, and probably also health. The northeast of England is one of the more deprived areas of the UK. We have higher rates of smoking-related illness, higher rates of alcohol-related illness, some higher rates of crime. We're a fair distance from London. London feels a long distance away, but there are problems around here with housing, with some social situations, and I have to know all that, and it's just important when considering what I do. But I'm extraordinarily proud to work here as a haematologist, showing you my sign there, the haematologist. And I want to talk a little bit about that. And hopefully this will make sense as we go on, just thinking about the area that you grew up in and the area that your patients have grown up in, what they are set up to feel, to think, to act, to respond, what their level of knowledge is, what they know about cancers, what they know about illness, what they know about blood. Who knows? Everybody's different, and you have to know your family, your friends, your area. I'm going to talk very briefly about being a haematologist. I'm a haematologist. I've been a consultant haematologist since 2001. And as you know, I trained in the area. And haematology, I think, comes with some reputation. We like to think of ourselves as this kind of safari man. You might recognize the scene from Jurassic Park, the fending off the dangers, the dinosaurs, the attacks that we get from red cells, from white cells and platelets. We're constantly seeing patients in terms of these numbers. Perhaps that's how we assess some people. Oh, the hemoglobin's all right today. Their white counts come down. Don't worry, today the platelet count's satisfactory. And these are the challenges I get on a regular basis. I've made sure my emails are turned off. It's a thing that regularly pings telling me about somebody's blood count. I've just been told, for instance, before I started this, somebody who's on anticoagulant, one of my patients, their platelet count is now 20. I've got all that to think about, and it's going on in the back of my head. How am I going to sort that out? So the day job feels very, very much like this. We're constantly fending off this sort of situational knowledge, and we have a huge insight into patients' biology and their disease, how things are going. We might actually know about things before the patient does, in terms of watching blood counts change, seeing the pattern of blood tests, seeing how things are responding to treatment and to time passing, or maybe not improving, or not getting the way that we think they should be. So it's something I'm aware of as haematologists, puts us in a slightly unique position, that deep involvement in a patient's biology, in the biology of their cancer, of their illness. And it sometimes gives us an insight into what's going to happen, how things might be panning out, what the pace of change might be. And I think it means that haematologists are often in a position where we are quite frequently breaking bad news. We're quite frequently discussing prognosis and what might happen. We have to be reasonably good at managing uncertainty as well. And there is a lot of uncertainty in haematology. We know that diseases should respond, but don't always, and vice versa. So I'm often amazed at how quickly and rapidly we get involved with things. The classic situation for me, and the worst situation that I could think about when breaking bad news, is seeing a blood film that looks like this on a Friday afternoon. You see a blood count come through from the lab. The lab are tracking me down, and they're saying, Chris, we've just seen this blood count come through. Clinical details might say unwell, bruising. It could be a 10-year-old, 20-year-old, 50-year-old, 70-year-old. The stories are all tragic, and some more tragic than others. But we see these blood counts, we see these blood films, and we know that somebody's got acute leukemia. And you go into that mode, right? There's only one thing that can happen now. I am going to have to be going down and telling somebody and talking through a very serious diagnosis. Sometimes that might be via somebody else. I might be at a distance. I might not be on site. It might be a colleague I need to speak to. It might be the doctor that's looking after them in the emergency care department I have to speak to on the phone. But inevitably, I'm going to end up seeing a patient and going through what I've just seen and what all this might mean. So I know those kind of things. I know what I would think. I know what I would think because I'm a 53-year-old haematologist from Newcastle. I've got a lot of knowledge when it comes to a blood film that looks like that. I know what's going to happen. I know what treatment's going to be coming. I know what my risks are over the next few days. And so much of that information has to be crammed into a very short conversation with a patient. And that's a lot to take in. It's taken me years to have a familiarity with leukemia. We do exams in it, we train in it, we see it, we work with colleagues, we have large multidisciplinary teams, we have people we can talk to about all those difficult decisions. And you're somehow going to have to get all of your knowledge and skills and condense it into some short conversations about breaking news about something like this. So I think when we're going to talk about bad news, we need to know what doctors are like. That's why I told you what I'm like. And I've observed so many different types of doctors over the years, so many different ways of doing this. There's no right way, there's no wrong way. Well, perhaps there are a few wrong ways. You've probably seen those. But doctors are a slightly different group. I don't think pathologists are a different group, or physicians or surgeons, but doctors come at illness with different eyes that have been changed by time, practice, skills, knowledge, reading, experience, bad stories, good stories, single cases. Lots of things change our practice and lots of things change how we think. So I'm going straight into a more factual slide that might be of interest to you. And I'll just take myself off the picture for a second, just so you can see this a little bit more detail. This is some data from the John Hopkins Precursors study. So a lot of information on one slide. A large American study surveying doctors on a regular basis. I think it was 1948 or something this started, following up doctors and what decisions they might make about their health. And when you survey doctors about what they would want doing if they knew they had a very, very serious illness. So I'm drawing some parallels with leukemia, but the illness that we're talking about here is that this hypothetical situation was brain death, I think it was, or terminal diagnosis, or something that might be very, very catastrophic. And options have been explored. And there's two bits of data displayed here. The results of the survey in 1999 versus 3 or 4 years later. That was just comparing the persistence of belief. But you've maybe been reading the slide as I've been chatting, and you can see what proportion of doctors, physicians, wanted these various interventions. And you can look through those. There's cardiovascular resuscitation all the way through to nasogastric tubes or antibiotics if you're approaching the end of life. And I want you to look at that and then compare what you're doing, your own practice. Is this what you're offering your patients, considering it's what you would want? I'm typing you in, like we've already said, different cultures, different practices. This is fairly reproducible across most groups of physicians. And the evidence seems to be that physicians will choose far less intervention for themselves than they decide to choose for their patients. So already going into this whole conversation, there's a discrepancy. What you would choose for yourself versus what you might go ahead and recommend for your patients. And why does that difference exist? Why are we so willing to pull the plug on ourselves, but not really to pull the plug on our patients or to see things? And is that because we just know things? Is it because we're cynical, because we've lost faith, we've lost hope? Or is it more that we have that very, very deep understanding of what the risks and benefits of all of these interventions are? What it feels like to have a tube, what the benefits are from that, what the risks are, and perhaps we know our risks would be better without some of these things. I remember the huge surprise I had when it comes to surgery. I remember speaking to a surgeon when one of my patients developed appendicitis, and right, we're going to operate, aren't we? And the surgeon said, "Do you know, Chris, the evidence behind operations in appendectomy in certain situations is actually very limited. A large number of people with appendicitis, it will settle on their own accord. And perhaps in this elderly, unfit patient with cancer, the right thing to do is just to watch." And it had never dawned on me that you could not operate. And this is a younger version of me. And you keep seeing recurring themes like this. The experienced surgeon who says, "Don't operate." It's that valued surgeon, that valued colleague that you might just keep friends with over the years. And hopefully you've absorbed some of this information as I've been talking, and gives you that much clearer idea of your own thinking versus how we might say things to our patients. There's a slightly pretty way of saying this. There's a lovely picture that you can see. A little summary. Basically, if you ask doctors how many of them would want ventilation, 87% would say no, thank you. And you can read some of this data. I'm going to show you this meteor slides following this one. It's just important to recognize this. This is very telling. And what's very telling with this is that the number of people who would want opiates and decent pain relief is where a lot of our thoughts lie ourselves. So I've provided links to some of this data, and you'll see that, and hopefully you'll have a copy of the slides, and you can read the papers in a little bit more detail, absorb them, and develop your own thoughts about your own practice. These are the kind of the big papers studying physicians. So what I've shown you on the last couple of slides was how physicians would choose things, and then this is evidence about what they actually do. So this is when physicians or even lawyers, I like this paper, when patients who are physicians are in hospital or lawyers who are in hospital, what actually happens to them? Do these wishes that we've just seen written down actually turn into actual actions? And you can hopefully pick out through the data where there's some significant difference. I think this column, we've got an adjusted population, and we've got the unadjusted over there. We're comparing physicians to that and lawyers to the general population. Some evidence there that more of us would choose to die at home, fewer of us would choose surgery, and fewer of us would spend time on intensive care units. Please read these, please absorb these at a later time. The evidence is there to back up what people see and what people feel and what people assume. Another big study comparing physicians with non-physicians coming out of JAMA, and you'll be able to see through this when you read later on about how physicians will be different in terms of admissions and all of those things that we talked about. The numbers perhaps won't look as dramatic because they're based on huge studies, but you will spot the significant different columns, the increased use of palliative care amongst physicians to non-physicians, keeping people at home, less CPR, fewer tracheostomies. All of the evidence is there that physicians will choose different things. So the problem with this situation, what we're showing here now, is that perhaps we aren't quite understanding our patients. Are we transferring our knowledge? Are we denying them knowledge? Are we failing to learn more about our patients? This is what would happen to us if we really knew everything. So I want to introduce you to a little story. This is a story about spoons, and you probably think I'm a little bit strange for talking about spoons, but go with me. So this is a spoon in a field. It's a giant sculpture. It's about 4 miles that way for me. And this is a hospital in the background there that I work in. So our hospitals around this region are all linked together, and our acutely unwell patients go to that hospital that you can just see on the horizon there. That hospital's within about half a mile of this spoon. And interestingly enough, hopefully you can see my arrow, one of the things that overlooks this spoon is our intensive care unit on the top floor of the hospital just there. And not long after this hospital opened, it's only been open 4 or 5 years, I was standing in that window looking out the hospital, and one of the nurses said, "Chris, can you see that spoon?" And I thought she was crazy. What spoon? That giant spoon on the horizon. There's a spoon. Can you not see it? And I couldn't see it at all. It was this sort of little dark shape. So I looked it up, and there is a spoon in the edge of a field, and it's about 7 feet tall, maybe a little bit bigger. You can stand up in this, and there's lots of photographs of children up to filling this. And it was done by an artist called Bob Budd. And he's known for sort of public art, and he has a few art pieces spread around the country. And he chose this place for his spoon. And when asked why there should be a spoon at the edge of a field, he said, "It's a perfectly logical place for a spoon to be." And he was trying to illustrate the bounty of the land, the production of the land. And and it's just a strange story. But the reason I'm mentioning it to you is because spoons are a symbol of a group of people called spoonies. You may never have heard of spoonies. It's a very active community on the internet. And comes from an essay written by somebody called Christine Miserandino. And she wrote this essay in 2003. And she has systemic lupus erythematosus. And she struggled with trying to get her doctors to understand why and what her tiredness felt like. Her tiredness ground her down. Her tiredness was overwhelming. Her tiredness was exhausting. And she found that her physicians couldn't understand it. And a story goes that she was in a conference and in a hotel, and she just grabbed some spoons off a table, a handful of teaspoons, and said, "My energy is like this. I've only got this number of spoons at the start of the day. And every time I do something, I get rid of a spoon, and that's one spoon gone. If I get up, wash and shower and get my hair done, that's another 2 spoons gone. If I go downstairs and have to make my children breakfast, there's another spoon gone. And I've only got 10 spoons. It's 10 o'clock in the morning and I've got 2 spoons left. And I know if I spend those 2 spoons, I will be exhausted. I won't be able to carry on for the day. I will be just won't have the energy. It's this idea of finite amount of energy, and she'll only get those spoons back if she sleeps for a night." And she was just trying to convey this idea of spoons and tiredness, because the problem that she's had when her doctors are treating her, they were just using all the biochemical parameters in her SLE, measuring, cutting, sticking, doing this. She said, "No one ever asks me about my tiredness. Nobody tells me how to manage that. There's no trials or study or data that tells me how to improve tiredness. And that's what's important to me. I don't have the energy to do anything anymore." And if you think through these things, how many of our diseases do we use the wrong surrogate marker, or the marker that isn't actually important to the patient? We see things like comparing the priorities in hematology at the efficacy of drugs in myeloma. And we look at progression-free survival, we look at bony disease, but do we look at energy, tiredness, hair loss, respiratory problems, things that stop people doing the things that they love? Lymphoma and itch would be another big one. I've never seen a single study anywhere that's about, a basis of treatment being controlling the uncontrollable itch. And I hope you're sort of seeing the reason I think this is so nice then is we've got this spoon as the symbol of chronic disease, of the patient who's trying to deal with their illness, their life, and their problems. And then behind it is the acute, big, shiny hospital. And that big, shiny hospital might be involved with that patient perhaps 0.01% of the time. 99.9% of patients' care is self-directed. It's at home. It's about doing the things that they love. It's about going to that nice beach, that nice shop, those nice bridges that you just saw. These are the things that people who've got a serious illness are prioritizing more than anything else. Not the white cell count, not the platelet count. It's what they want to do. And if you ever survey the top 10 regrets of the dying, they will tell you they wish they didn't work so much. They wish they'd lived more for themselves. They wish they'd stayed in touch with friends. They wish they were happier. They wish they cared less about what others thought about them. And they wish that they didn't take life for granted and lived more in the now. And I think doctors We know people want to live longer, but we need to be aware of modern medicine and its limits. And we've got to be careful with what we promise, with what we say, and we've got to respect patients' choice and patients' thoughts and what's important to them. And this is going to be a big part of when it comes to that model about bad news and what you do, thinking about what's important to your patients. I've asked why this is important. I've just said it's about knowing what your patients are. And this is a really, really important graph when it comes to healthcare medicine. And this comes from some original work in 1980 and taken on by somebody called Professor Sir Muir Gray, who you'll see if you Google his name and look him up. He's been involved in several very high-level discussions about health economics. So as well as wanting to get everything right for our patients, there are other reasons for wanting to get things right. And we've got to talk about the bluntness of health economy. Managing health is expensive. Doing things to people is expensive. And it's very, very easy just to do everything, to keep throwing resources at the problem, to spend more money. And the evidence is very, very clear. In the last 6 months of life, we can spend an inordinate amount of money on all of those interventions that we've just talked about. So being, without trying to be cruel or unjust, we've got to think about this fairness. The reality is that our budget isn't limitless. We do have to be sensible, and we've got to think about how resources are spent and where they go. And I hope you've followed through the implications of what you're seeing with this. As we improve, as we push more and more interventions and tests and chemotherapy and things at patients, that's how our resources go up. And because of who we're applying these things to and getting further and further towards end of life, the risk of harm of any of these procedures will keep rising as patients have been through more, got older, had worse health problems. That harm curve, well, line is going up. And of course, initially, when we do things for people, we're getting benefits. And the benefit that we get from early interventions in the early stage of disease is phenomenal. And there's an almost exponential rise in benefit as we use different drugs in that first few months or years, even of chemotherapy, of treating diseases, whatever disease you might mention. But at some point, those interventions start making less and less difference. You've probably seen the papers where there are enormous cohorts of people with a 2.5% improved survival, and they're starting to get small. So those benefits tail off as you go up. And eventually that benefits curve is hardly rising, perhaps slightly, but the harm curve keeps going up and up and up. And when you start considering the benefit to harm ratio, there's a point where you cross, where throwing more resources becomes financially silly, where it becomes harmful, where it could become futile. And if you're looking at this from an individual's perspective, that's the point where it's really, really hard to recognize that point of futility. And it's hard, I think, particularly for hematology, oncology, and many, many other clinicians who've looked after their patients for years. When you've supported somebody for 10 or for 20 years, like I might for somebody with myeloma, it's sometimes really difficult to spot on that trajectory where this has happened. It's difficult to recognize yourself. It's very difficult for the team to recognize that. And it might actually be the patient or the patient's relatives that spot that more than anything. And it's a problem again with healthcare, recognizing when harm is outweighing benefit. And it can be really difficult to recognize that. It can be really difficult to recognize those last few months of life, those last 100 days. Can you imagine the currency, the importance of those last 100 days? As clinicians, how important is it to identify that last 6 months, that last 100 days? We owe it to our patients to be truthful and honest and clear when we think we're in that situation when we might have to break that bad news. You might have your own little clock for when that happens. For me, it's when patients are in and out of hospital, when things aren't happening like they should, when there's that frustration inside you that things aren't getting better, when patients are losing weight, becoming immobile, stuck in bed all the time. Those bells have to go off in your head that there's some bad news coming. So I'm relating this back to this whole session. It's about recognizing when bad news is coming. It's about recognizing when you need to tell bad news. It's about recognizing that your priorities might not be the same as the patient's priorities, and you might need to start thinking about something else, not just conveying the bad news, what's coming after these things. So lots and lots of things to think about. And then what I want you to think about now is that we're really, really rubbish at saying what we mean. And I chose four of the funniest phrases I could think about for dying. And this is the bit where I wish I could interact with my audience to know what you all say, to know what other people describe the act of death or being dead. So some of these are English phrases. Some of them are a little bit Geordie. So Geordie is the other name for where I grew up, Newcastle, that people from this area are called Geordies. And one of the phrases is carked it. It just sounds so blunt, doesn't it? Carked it, that means dying. Kicking the bucket, kick the bucket. You've heard these things. Croak, croaked, croaking, pushing up the daisies, feeding the worms. There's all these other things. Yeah, we have these euphemisms all over the place for when it comes to people who have died, who are no longer with us, and once you start watching them, I see them so often in the news, and when you're hearing people talk about relatives, and it's nice, of course it's nice, but it's hiding a truth. I think the one that I heard a few weeks ago that I really never heard before was crossing the rainbow. Okay, and it's just I know what you're saying, I know what you're trying to say in this, but it's just because we're not saying the right things. We're another star in the sky. They've moved on, they've passed, they've slipped away. And to quote a colleague who you're going to see at the end of this session, we're just not very good at the D words. We're not very good at saying what we mean. We say people are unwell. We say people are getting worse. We say people are seriously ill. This is the doctor speak section. This is the words that if you or I were in hospital and we heard the doctor saying, you or I would know these are bad things. But what are they actually conveying to your patients and their patients' relatives? Are these words good words, bad words, in between words? We know what they mean, but they could mean something very, very different to your patients. Even if you think about how we use the words acute and chronic, that's not understood by the general population. In Geordies, for Newcastle people, chronic is a word that we might use to describe bad things. Oh, that's chronic. And whereas chronic myeloid leukemia, hang on, we're in a whole different area here at something that you'll probably live a normal lifespan with. So we're not very good at the D words. We don't like saying dead. We don't like saying dying. And we would very rarely say, your mum is ill enough that she might die. These are clearer words. These are things that will help families, friends understand what's happening to their relative who's in hospital, not some of those other wishy-washy words that you've just seen go past on the screen. And again, we've got to think about why it's important. Using words like this will help families know what to say, how to handle, how to work, how to think, how to plan. There is so much that you have to do when someone might die, when somebody is ill enough to die. There could be things that you need to do as a family, sorting out a will, sorting out power of attorney, the legal issues, the house sale, whatever. It's so much better that families know when somebody is at that point. The practical things, as well as coming into the hospital, getting people home, doing all of those useful things. So this is about language now and why it's important to get things right. And there's another reason for getting it right. You're helping, and going through grief is a horrible thing, and helping it happen in advance, being aware that somebody might die. I know that the bad news that we're talking about might not be about death. It might be that the bad news that we're breaking is something that affects their pension, their insurance, lots of things. But for the purpose of this talk, I'm talking about people who we're giving the worst bad news, people who might end up dying very soon. And your duty of care extends to their family as well. Doing this right will help them. It will help them deal with the forthcoming death, bereavement, and the grieving process. And I know every one of you in this room listening to this has probably been through the grieving process. My dad died early on in COVID. And I took a while to think through that. And I recognize, as I looked up the medical explanation of grief, the medicalization bits, grief is a horrible thing. But it's a normal process. It's what happens. And that's the stages that we all recognize: the disbelief, the shock, that feeling numb, and those stages that we go through of guilt and crying, but gradually moving on to an acceptance, an ability to think about people without crying, an ability to think about people without melting, to remember some of the happy things as well as some of the sad things. But there's very physical things. So you've got to owe your families and your patients' families a duty to help them manage grief. I saw a lovely model of grief, and I think it's something nice to understand. Some of you might have heard about the ball in the box model of grief and understanding grief, and this one has helped me when I was going through things, and it's helped me talk a few family members through things. And if you imagine there's a ball in a box, and inside that box there's a big red button. And every time the ball hits the button, that's what causes those physical things, that overwhelming upset of grief, that melting of your insides, that palpitation, that the insomnia, whatever it is, the symptoms of grief happen when that button is pressed by the ball. And when you've just had a relative die, that box has got a very, very big ball in it. And that ball is bouncing around and it's hitting the button all the time. It just keeps hitting that pain button, that grief button. And with time, the ball gets smaller. And it's a lovely way of thinking through this. So the ball can bounce around in there and it won't hit the grief button quite as often, but it will every now and again. It'll happen randomly. It'll happen with memories. It'll happen at certain moments, little reminders, and bang, it hits that red button. And it never quite goes away. This model, it's just a model. It's just some way of thinking about it and explaining things, but it's a very helpful way of talking it through. So over time, you can expect that ball to get smaller, and the grief gets easier. It doesn't happen quite as often, may never disappear, but it's what happens with time, and that's normal. Because what you don't want and what you hope to prevent is prolonged grief. And I think we've seen more of this with COVID. We've seen more of this with what's been going on in the world at the moment. And people are more prone to this situation in certain situations if you already have a history of depression or other mental health issues, or if you haven't been helped and supported and explained by your relative's doctor. These are all things that can put you at risk. And 12 months later, if you're still having psychic pain, distress, you're still ruminating about things, you're still blaming things, you're still wondering about what if, you're still seeking things, perhaps you have a prolonged grief disorder, perhaps you need help. And these are times when you do need help. You might need psychiatric help, you might need counseling, you might need people to go through things. And this is why we have to get it right. So as well as getting it right for our patients and helping them understand, helping them be clear, helping them know that they're in that last 6 months, that last 100 days, making sure they have the time to do the things they love, the things that they enjoy. We're also helping the health economy. We're also helping our colleagues. We're also helping the patients' families. There are so many reasons to get this right. It's not just a simple, straight up model of breaking bad news. There is lots to think about. And I hope I've given you several strands to know why this is so important. I'm just going to talk through one model of breaking bad news, and that's the spikes model. There are others. I think when I'm breaking bad news now, I'm probably using a few bits of all of them, but the spikes is a good one to talk through. And so that's what I'm just going to do for the next few slides. Just run through what the spikes model is and give you a little bit of a hand for the next time you might have to go and break some bad news to somebody. So S is for the setup. And I think I've been setting you lot up for the last 20 minutes, half an hour, thinking about things, planning, working it through, getting it right. Who needs to be in this room? Are the right people here? I'm not walking in and telling you bad news. I'm going to be walking and saying, I need to have a chat. Could I arrange to get you together? Who else needs to be here? We need to be in a room that's quiet, good seating, good lighting, the door's closed, the phone's off, your bleeps away, the buzzy things around your neck are all cared for. You can give somebody time, place, and your presence. You have to be there, and your undivided attention has to be in the room. So get that right. Usually useful to do it with somebody else. Two of you in the room can be very, very helpful, but make sure the right people, right place. So that's S for the setup. P is for perception. What are they thinking? What do they know? Where are they right now? And what I'm meaning by that is, when you're coming in to tell them bad news, are they expecting it? Have they already got some knowledge? Is this right out of the left field? Do they understand their illness? Have they read? Do they understood? What do they think? What do they understand? Because you need to know, in that journey that maybe you could consider yourself here, I know everything about illness and treatment and risks and benefits. Where's the patient on that? How much do they know about their illness, their treatment, their risks, their prognosis? What have they been told so far? Where are you coming in on that ladder? So you know how to tailor your news. You know where you come in, and you might need to start again with explaining biology, with explaining you've come in today with bruises. We do a blood count, and that blood count's looking at how your blood and clotting works and how all the cells are there. And we found a problem with this. Giving people pauses to check that they understand, tailoring the information to them. You might find that somebody at this point isn't ready to talk. It's all right to step down again. You might say, can we talk again later? Is there anybody else that you want me to talk to? So it's about keeping your questions open, listening, working out where that patient is in that big ladder of understanding things. I is for information. Is this the right time to be doing this? Can I talk to you in a bit more detail? Can we talk about your illness? Can we talk about your health? They may not want you to speak now. They might want you to come back later. You're going to have to be sensitive. You've got to be speaking clearly. Watch your euphemisms. Watch those silly words. Watch the language that you're using. Be nice and direct, but sensitive. K is for your knowledge, the imparting of knowledge, the giving of knowledge. And this is usually, most people would suggest, a warning shot. And the warning shot is that classic phrase, I need to give you some important news. I need to give you some serious news. I need to talk about your illness. Can we do that now, please? Just checking, that's that person. It's another check in the step. This is when you then start talking in detail about what is going on. The various steps that you might go through will depend on where that patient is. Whether that's a case of just layering things, that's how I've tended to find things has been helpful. When you know that somebody's listening, we've checked your blood because you were bruising. When we check your blood, we found that there are some cells in your blood that are abnormal. Those cells have been looked at under the microscope, and we can tell there's a very serious problem with your bone marrow. Is it okay if I explain what that is? And you can go on from there. Not everybody might want information. Not everybody wants it in the same way. You have to do it slowly and sensitively as you do these things. Be human. We're all humans. Keep being human. Don't turn into a robot. Don't forget about feelings. Please accept that the person in front of you is different to you. You mustn't make assumptions about their knowledge, their skills, their reactions, what they want, what they don't want. You can't prejudge anybody. I've seen all sorts of things happen. You think that people will collapse and fall apart, and they don't. You think that somebody isn't ready for this information, but they are. You have to be listening. Listen to questions, listen again and again. Listening isn't doing nothing. Listening can be the single best thing that you do. Respect, acknowledge their concerns, acknowledge their questions, give them time to ask you about the information that you've given them. S is for summarizing, and this is thinking about the next steps. Make sure they understand, make sure that they can really know what you've been talking about, that there's no uncertainty about what's there. Give them information if they want that. Have a next step. Somebody told me this is like having a date. Always have a next date. Always have something else planned. Always have an option. Whether that option is we'll meet again later on today. We're going to talk again tomorrow. I'm going to ask a colleague to come and see you. We're going to be talking about managing your pain next. There's always a what next. And patients should always know that. You're never giving up. You're never stopping caring. You're always going to be caring. You need to document this very clearly. You need to ensure that they could consider documenting it, writing notes, keeping a notebook, keeping a journal. People will have lots of questions. You're with them for 5 or 10 minutes. They have 24 hours of just thinking about what you did. So make sure they've got a pen, a paper, and that they're thinking about things. They always know what's happening next. And that's the spikes model. Setup, perception, invitation, knowledge, empathy, summary. It's a model. You can read them all. I think the best thing is knowing the patient. And that's why I started off going on and on about Newcastle, because there's something you've got to do. And it's why I talked about spoons and why we're talking about those things. What's important to that patient when you're having this conversation? If you know that the most important thing to that patient is spending time with family, time in the garden, time in their little holiday house on the coast, their dog, their wife, their best friend, a nice coffee and a cake at the seaside. These are all the things that provide a bit of joy, and you knowing and helping people achieve those things, it's what's important. I've got another picture of myself. One of the things that I think we mustn't underestimate is looking after yourself through all of this. It's really hard, and it's something that will prey on your mind, bad news. You worry about giving it, you'll think about giving it, and you don't like doing it. There's a little bit of me wants to remind you all, don't forget, this isn't your news. I say that as a little bit of a defense in some ways. This isn't your news. The bad news isn't about you. You're not sorry that. This is the patient's information. This is theirs. That's their information. It's not you. It's not about you. Don't make it about you when you're breaking bad news. You don't have to be, I don't think, saying sorry. That you're not sorry. You have a duty to give people information. You do that empathetically and sympathetically in a nice way. That's not the same as being sorry. It's not your fault. It's nobody's fault. That's the wrong theme with all of this. And I just think sometimes people get a little bit stuck with blaming themselves or finding this hard. And I think it's always going to be hard, but it's part of the job of being a doctor. And one of the things I was asked to cover in this session was about coping with grief, coping with breaking bad news as a physician, as a doctor. And there's my horrible hairy legs. There's me on a bike, and I cycle to work every day, and I cycle home every day. And that 30, 40 minutes I have every day is just my bit of time when the brain empties a little bit, when it becomes a bit easier, when I think. And I nearly ran somebody over the other day. I was thinking so much. He was right in front of me on the path. Nearly hit him full on. I think he thought I was completely stupid. Exercise. It's good for you. I'm going to do the doctor bit. Eat well, sleep well. Don't drink too much. Eat the right things. Talk with friends. Write stories. Read stories. Watch TV. Listen to the radio. Do the things that you love as well. I've talked about making sure you know what patients love. Make sure you do what you love as well. And if you're struggling, find help. If you're struggling, talk to a counselor, talk to a colleague, talk to your doctor. You have mental health to look after too. And don't underestimate that. Don't turn into a robot. Keep your humanity, and know and trust friends who say, you're not right. Chris, do you need a break? Chris, can I do that for you? Let them. If people are saying those things to you, it's probably because you actually need a break. So listen to your friends, listen to your colleagues, listen to your partners, look after yourselves. I'll try and get you all cycling if I could. It's just been the single best thing I ever did to help keep healthy and to help keep me well. So that's all I want to talk about with looking after yourselves and coping. But I've got a couple of other resources for you to look at, and I hope you can find some of these across libraries, across the internet. If you want to read a little bit more about understanding death, understanding dying, understanding difficult conversations, understanding how people think and act in those most difficult of times, there's a huge selection of good stuff. This was the first book that I read about this, Being Mortal by Atul Gawande, an incredible book talking about the journey he goes on as a surgeon with his dad dying of cancer. And you see the epiphanies one after the other. And he also shares this in a beautifully written way. The Royal College of Physicians produces this, which is all available online, talking about dying and structured conversations. Scotland produces the paper on my left, which is called Realistic Medicine. That's from the National Health Service in Scotland. Really interesting thing to look up and work through. The Academy of Medical Royal Colleges up there about writing patients, about communicating information to patients. That's a really useful one. And then this book, With the End in Mind, from someone called Kath Mannix, who is from the northeast of England, who I've worked with, who are proud to say I know a little bit. And if there's a book to read, it's that one, and Being Mortal. And Kath shares stories of places and times. Some of them are a little bit familiar to me, but she shares that in a style that's easy to read, easy to think. And this has even been books that I've recommended to families as well. People thinking about life and thinking about their relatives can need a little bit of help and a bit of reading, and these are great resources to point people to as well, those two books. So keep an eye on those two. And if you want to see Kath in action, you can Google Kath Mannix, and this is a video that's had hundreds and hundreds of thousands of views now. She does lots of talks about dying, about the fear that people have of using the D word. And she's got a lovely video, just about 4 minutes long, and you can see what it's called there. Dying is not as bad as you think. And this is for that really difficult conversation where people might need to know what's going to happen to me, what's going to happen to my mum, what's it going to be like. And Kath does this in a very, very reassuring way, reminding us all that dying is a process. Trying to keep smiling while talking about death and dying. They're the ultimate bad news. And what I've talked about for the last half hour has got every connotation. We could be talking about little bits of bad news through to the ultimate bad news of someone is dying in front of your eyes. Obviously, you have to tailor what we've talked about to the situation that you're in. But hopefully I've given you some ideas about understanding culture, understanding patients' priorities, understanding what your brain's thinking and why your brain thinks like that, so you don't assume that with your patients. Patients need information in a way that means something to them, that's important to them, that takes accounts of their knowledge, that is understanding and is for them and by them. It's important to do that well. It's important to do that well with patients and their relatives, to keep them well, to help them manage the grief process, the practicalities, and then after their relative has died. It's also important for the health system as a whole that we recognize death and dying, that we recognize bad news, that we aren't afraid to talk about it and make sure. The evidence is very clear that when people know that they're in those last 6 months, that they will use healthcare resources more efficiently, more effectively, they'll bother people less, and ultimately there'll be less money spent on them, in the kind of bluntest way, but that's because their care will be better, more at home, and more focused around what that patient wants. I have one concluding slide to tell you, which is some work we've done in our hospital, and it's shared from several sources, and you'll have seen that from the slide two slides ago. Another way of having conversations that can help start a bad news conversation. This is really, really helpful in any illness at any time, for any investigation or any intervention that you might be planning. We encourage our patients to ask us 4 questions. So this is patient-driven fact finding. What are my options? How can I get some information from you as my doctor to make a decision together that's right for me? And there's the hint. That's understanding people, their points of views, their priorities, what's important to them. You mustn't assume that because your priority is your wife and your children, that your patient's priority might not be their garden or their birds or their pet dog. You just don't know. Don't assume a thing. And when you're talking about doing something to people, be very, very clear what the benefits are and what the risks are. Because at some point, the two might flip around and the risks are just too much. But that might be what your patient wants. And then the best question, the question that I think is the one that's really, really key, is what would happen if I chose to do nothing? And you can ask that as a clinician, you can talk about it as a clinician. And that's when you start heading down the prognosis. What's going to happen? What's coming next, doctor? We owe it to patients. We owe it to patients to do this right. We mustn't shy away from talking about death and dying. We mustn't shy away from doing it in a compassionate and human way. I hope this has been helpful. I hope it's something that's meaningful for you all. And I hope very much this has been useful for your practice.